still in 2011. He has been a physical therapist for 13 years, 8 of his years at Spooner. Fun fact about Nick, Nick hated reading until about 4 years ago, and currently is pursuing the Stephen King Chronicles of 35 books. I believe he is certifiably crazy. Nick is also known for an incredible beard growing capability, although it is not proof because he just shaved it, but in probably 3 weeks, it'll be big, full, and bushy. The third member of our team is Eric Brown. Eric graduated in 2018 from NAU and has spent his entire tenure of 6 years treating here at Spooner. Eric is a fantastic pickleball player and is ranked 5.0 plus. Therefore, you do not want to play him or you will get a pickleball to the face. Additionally, so thank you, gentlemen, for joining us on this therapist panel. We are going to do something different with these 3 gentlemen, and we are going to do a part 2 series on July 16th. Where the 3 of them are going to come together and go through some clinical rationale and application on a patient. Anyone who wants to attend can come in person from 12:15 to 1:30 in the Scottsdale treatment clinic, and we will also be live streaming it. So just keep that on your calendars. That'll be separate from the LMI panel, but this is something that we wanted to add secondary to the specific clinical application. So now let's get to our panelists. Enough of me talking. So let's start, John, with you, and then we'll work our way down to all 3 of you are going to answer this first question. What path did you take to pursue your advanced clinical certification, and why did you select that path?
Yeah, so I went through the Gray Institute's 40-week fellowship program, GIFT. You become a fellow of applied functional science once you go through it. I concurrently got my FMR certification, which is functional manual reaction, which is the Gray Institute's manual certification, how to use your hands to facilitate a desired chain reaction as opposed to doing manual on the table. My mentor my first year was a GIFT fellow, so I kind of knew that was the route I wanted to take. I really like the principles that how we treated his patients, a lot of the same principles that Spooner's kind of founded on, treating someone's mind, body, and spirit, treating someone 3-dimensionally, treating someone functionally, again, chain reaction biomechanics, all that kind of fun stuff.
Nick.
I pursued the CFMT through the IPA, the Institute of Physical Art. I didn't start that certification process until about 3 years ago, so I was a bit further into my career. And the reason I was pursuing something is because I found that there was a gap in my care, and there was a certain percentage of patients that I was unable to get to the point where I needed them to or wanted them to. So after being exposed to the IPA's approach, it resonated with me, and I saw the evidence of the effectiveness of it. And so after experiencing that, I pursued that, and it took me a little while to finally commit to the route, but I finally did, and then completed that just last year.
I did my COMT through Phoenix Manual Therapy, which is based right out of the Biltmore area. I started that about 2 years ago. It took me about 1.5 years, I think, to complete it, although you can do it a little bit faster if you want. But kind of like what Nick said, I kind of felt like there was a gap in what I knew, and I wanted to get better both with my hands and my clinical reasoning. And I took one class just kind of as a trial to see if I liked it, and I thought it was really kind of eye-opening, and so I ended up continuing on through it and eventually decided to do the whole certification.
So as you have heard, we have 3 completely but yet similar paths to pursue advanced clinical certification. And so my next question is, John, you did yours earlier in your career. Nick, you did yours a little bit later in your career. And Eric, you're kind of in the middle of your career because you're the old guy sitting at the table beside me. So not that you're old, but relatively speaking. So kind of want you guys to articulate on the timing of when you went through your clinical certification, and if you feel that, looking back, you wish you would have done it sooner, if you would have done it later, or if you're happy with the timing that you did. And let's go the opposite direction. So Eric, start with you.
So I took mine, I started thinking my 4th year is about when I started. I think knowing now, I would have started it earlier. I think I would have started with those courses. So I'd taken a couple courses before that were good, and they helped kind of guide me through my own clinical reasoning and growth. But what I liked about it was not only that, even though it's called you're a manual therapist, but you're learning clinical reasoning and everything as well. And I think there's so much power in that aspect of it that I think yes, I learned new skills, I learned new treatment techniques, but I thought what was best was just how I'm thinking through patients. And I feel like just my efficiency with making decisions in the moment got much faster, more efficient, and I was able to progress people more quickly, and give them stuff that's more relevant to them and kind of mimics what I was doing. If I did something successfully on the table, here's how we can advance it, make it resisted, and here's your homework that builds on it. And I feel like everything kind of built on itself really nicely. So obviously I'm so happy I took it early, although I've encouraged some of our clinicians to start doing some of their courses earlier if they like it, Jeanette being one of them. So I think it's a good starter course, because I think most people, when they come in, it's like you just need to learn how to think still. Like, you have a lot of techniques, you have a lot of practice, but it's just thinking through these cases and knowing how to maneuver that is the most important thing.
I was first introduced to IPA when I was about 6 years into my career, and then didn't commit to the actual certification route until another 3 years after that. So I do wish that I had started this earlier. I'm going to give a little nod to Spooner at this, because my previous employer didn't really support a lot of the continuing education the way that Spooner does. And so when I was encouraged and supported on that realm and realized that these were options for me, that was kind of when I started to look at that. So I do wish I had started earlier, but I also appreciate the journey that I was on prior to that, how it molded my ability to analyze the information that was coming at me. So I mean, ultimately, I wish it would had started earlier, but it was still a good route, and it was still a valuable journey for me to take. There's a lot of coursework available through the Institute of Physical Art, some of which are part of the curriculum required for the certification, and some of that are not. And so there's a lot of opportunities to experience what the IPA has to offer. And so I kind of dabbled in that non-committedly for a few years before I jumped in and decided that this was something that I wanted to integrate a little more fully. So that was.
Yeah, I went through GIFT in my second year of treating. And again, I was lucky because my mentor was a GIFT fellow. So I already gotten a full year of GIFT principles and mentoring from him. So I knew it was the route I wanted to take. Doing it my second year, I didn't have a lot of bad habits I had to overcome, which I think was a nice thing. Also, it gave me a nice kind of like paradigm or framework to organize future Con Ed courses and mentoring and learning experiences against that treatment philosophy that I learned going through GIFT. Again, not a lot of bad habits. I was ultimately, though, like Nick kind of said, frustrated that I was not getting people better my first year, right? I just wasn't very good at my job. My job is get people better. I did what they taught me in school. It didn't work. I paid a lot of money, went to a lot of schooling, took a lot of time. People just it wasn't happening the way they told me it was going to in school. I just was frustrated. I felt like there was many things I was missing, couldn't connect a lot of dots. So going through GIFT helped me connect those dots, ultimately be a better therapist, and kind of, again, opened up the road to continue to progress my knowledge and skills. But again, having that framework to follow.
So you, all three of you kind of elaborated on what your advanced clinical certification has done from shaping your clinical thought process. I want you to expand a little bit deeper and give a few specifics on, I mean, Eric, you kind of touched on how, even though it's a certification in orthopedic manual therapy, it's more than just manual therapy. CFMT, certified functional manual therapist, yes, it's manual therapy, but it's more than just manual therapy. There's neurointegration, there's motor control, and yes, it's applied functional science, and there's principles of functional movement. But can you spend a little bit of time articulating on what it's done, especially you guys did it a little bit later, you did it right away, on your approach from a clinical thought process standpoint? You get to start this time.
Right. So yeah, so I had a few years under my belt before I started going through the courses with IPA. And so what I learned from them was there's little tweaks to every aspect of my treatment. So my evaluation, my treatment, as well as my plan of care, as well as the exercise prescription on the backside. So every little piece was kind of tweaked and elevated to a different level, and it allowed me to then integrate this into my brain a little bit better too. So when I was taught on how to be a little more specific with my evaluation and be a little more specific with my hand placement and my techniques and how to use belts for mobilizations and different tools and that kind of stuff. It just kind of took it to that level, to that kind of area that I wasn't really able to access in my treatment philosophy. And so it just opened those doors so that I can discover those areas and then take my patients through those doors. And again, just kind of the gap that I knew was in my care was filled with the training that I went through, and they kind of in each aspect showed me different ways that I could fill that gap and bridge that area. So
I thought Nick said it well when he said specificity too. I feel like when I came out, I remember doing a lot of new patient evaluations and having just like a laundry list of objective measures, but not necessarily a lot. I don't feel like it told me a lot. I had a lot of information, but I didn't really know what to do with it or how to interpret that. And so I think mine, I feel like there was a lot of, from not only just patient observation to manual assessment to movement assessment, everything. It was like the level of specificity that they would get into and how much they would look at it, and not letting small things kind of slip by. I feel like they would take so much information from a lot fewer tests. And so I feel like I've started to just get more efficient in what I was looking at, where it's like, I can take a lot of information, I can take a lot of objective data. But I feel like I got a lot more by being really diligent and really cognizant of what the patient in front of me was telling me, just by their posture, their movement, things like that. And then kind of using hands-on skills and things like that to go in and confirm that information or reject it if that was the case too. And so for me, I feel like I don't always feel like I need to take as much information, but I'm getting much more out of what I've got. And then even from that, it's like, before I'd give a big list of homework exercise program, and it's like now I feel like I give one or two things that mimic something that we've proven to be successful in the clinic. And I think that's powerful too, because I can show them like, hey, we did this technique, you got this result. Now we've like, here's how you can do it on your own. It's like it builds on itself and it evolves over time too. But I feel like not only from an objective, examination standpoint has it gotten more specific, but the exercises themselves mimic those things well, and I think are more relevant to the patient that I'm treating too.
Yeah, I definitely agree. Connecting the dots was why I went through GIFT, kind of like you alluded to. I just wasn't good at that, right? So like Ryan Neslin was great at that. He just understood function, understood all that stuff right out of school. It took me 40 weeks to get it. Even in school, they kind of teach you like, look at the joint above, look at the joint below, but I didn't really know how to integrate that. I didn't know how to connect the dots. So going through GIFT, I feel much more comfortable, not only understanding the chain reaction biomechanics of treating someone's neck to help their foot or treating someone's foot to help their shoulder, but I can also explain it to a patient. And I think, buy-in's a big key, kind of like you were saying. Most people want to be treated at the site of where it hurts, even if that's not the source of their injury. So being able to articulate why I'm treating someone's big toe to help their low back was very important to me. And again, I didn't understand that until I went through GIFT to learn that.
So, John, what have you taken since you've done your GIFT fellowship? Right, you did it year 2, and foundational for you, transformational for you in a very positive way. And a lot of people, they have the GIFT hangover, they have the post CFMT hangover, they have the post CONT hangover, but now what have you done to further your thought process and add to the ability to assist your patients achieve?
Yeah, so I pendulumed from function back to structure. So my next course was dry needling, right? You just get on a table, here's your origin insertion, here's I'm sticking a needle in it. No function required, right? Got my vestibular certification and then kind of worked my way back. I was still, of course, treating functioning in the clinic, but taking more IPA courses, taking more Gray Institute courses. Now I'm kind of really going into foot ankle biomechanics and orthotics, because again, if I'm going to treat someone's chain reaction biomechanics and they have feet and they walk and they have an issue at their foot ankle complex and I don't address it, I'm not going to be able to address up the chain. So that's kind of where I've gone.
Okay, so now Nick and Eric, let's go the opposite route. What did you guys take early on in your career that then ultimately led you to pursuing COMT through Phoenix Manual Therapy and CFMT through IPA?
Mine was a little disjointed. Like I didn't have the support in the Con Ed realm, and so like some of that was dictated for me. And so I would take a back course here and a shoulder course there, but it was all very orthopedic driven. But I didn't really have the foundation to build off of that much. So it was a lot of random orthopedic courses that like I could take bits and pieces from, but because I didn't really have like a strong foundation, it was difficult for me to put it together in a cohesive manner. So, so yeah, that was a lot of my,
Well, what else? I mean, you've done vestibular
but
certification.
that was since coming to Spooner. So
Right, yeah.
since coming to Spooner,
Yep.
I've done a number of vestibular courses, which it was nice to like lay that foundation. And then I took one Gary Gray course, the chain reaction course, and then jumped into the IPA route.
And then what's your needling?
Needling was back in 2012 or 13. And that was through the Connecticut. And so like this dates me. So that was before Arizona had a law on needling. So I took the course, I was needling for a year, and then Arizona sent out a cease and desist until they established rules on it. So I had to stop needling for a year until they established their rules, and then I could start again. So yeah, it's been all over the place.
So I started with a McKenzie course for the low back, which I liked a lot, and I thought that it gave me some structure. As far as like some framework to treat the low back, and that's it. Because I just felt like, again, I was kind of just taking a bunch of measures and didn't really know what to do with it after that. And I liked it enough that I took the cervical course too. And it's been a helpful treatment paradigm for me. And I feel like there are some patients I really go down that route with. But they kind of claim that everybody can fit into that bubble. I would disagree that they can't, but if you do the certification, then you better make it work for them. But yeah, I thought it was helpful, but it just wasn't the right route for me to continue. And I still might go back and take some other courses eventually for their advanced stuff, but I don't think I could ever see myself treating completely that way. I did dry needling as well through structure and function, just because I feel like it was something that patients want. And I do think that there's a time and a place where you'll probably lose some patients if you can't needle. I mean, there are that come in that want that. And I do think it's a helpful thing to do, although I find myself doing it less often now than I did before. I did a TPI course. It was fine. I wasn't wowed. I wasn't thrilled by it. And I did a couple strength and conditioning courses that I did like that talked about some of the basics for like squatting, deadlifting, pressing. And I like some of those. I feel like that's been helpful for actually coaching some patients through different movements.
What I can appreciate about all of your different paths is the eclectic nature that you all have, despite having advanced clinical certification. And I think the thing I want our audience to really realize is all of the things that you take have the ability to help patients when you apply them in the right manner. And I think that's what all of you would say, and knowing you all very well. And so it's about the time and the place on when you're going to pursue that. So let's go ahead.
I would also say that like the more courses that I take, the more I realize like they're not all that different, right? They're all very much connected. Even the vestibular stuff, like it's all tied together, and it's helpful to take these courses to like get a different perspective on how it ties into it, but it's not as segregated as I once believed it was. So,
Or that we may have once tried to create them as very segregated thought processes. So let's change gears a little bit and let's talk about your three's ability to be mentors in your clinic, in your regions, and some challenges you may have encountered with passing on your specific thought processes to others, or their ability to receive it and integrate it and connect the dots, use your language.
Yeah, the hardest thing about mentoring with applied functional science is function is such like a buzzword, functional exercise, everything's functional. Well, it's not. I mean, like, maybe it is a little bit, but like 10% functional is still functional, but is really like 90% functional, right? Could we do something that's a little bit more functional? And then, define what functional is. Is it functional for this patient's goals or task, or is it just a functional thing that you saw and decided to do it because it said functional? So that's been kind of a challenge, is to understand why it's functional. If not, let's define functional, and then let's work along that spectrum, making it more functional. And then, of course, you always have to go back to, well, why, because we're not really taught that in school. So then I have to explain, well, why are we trying to make it functional? Proprioceptors, everything else that you kind of learn through going through GIFT. My mentor would always ask me in my first year, why are you doing this exercise? How is that functional? I was kind of a smart aleck, so I would always try to come up with a good reason why it was functional. And so I got my nickname Clamshell Klein, which we can talk about at a minute. But yeah, so I mean, ultimately,
That might be a happy
We
hour.
can have a beer and talk. But, yeah, derailed my train of thought. So function.
Got you to laugh first.
Mentoring, it's been, oh, sorry, it's fun. Like, I love mentoring on it, right? Because I like to, someone's so focused on like, okay, I can't get this patient's knee better. Okay, well, what's their foot look like? What's their hip look like? What's T-spine look like? Stuff that students don't really think about or new therapists don't really think about. So that's why I really like mentoring about that.
One thing that I appreciated about IPA is they really emphasize the human anatomy. And so like when I try and pass this on to a student or a new grad, the foundational stuff is what I continue to emphasize. So the two things that I continue to push are know your anatomy and practice your palpation skills. If you can do well at those two things, a lot of the other stuff you can figure out and reason through. And so the curriculum through the CFMT route, there are some lower coursework and some upper coursework. And so it's easy. They made it easy to like figure out what information would be best to pass along to someone who's not as familiar with these concepts. And so I push anatomy a lot, I push palpation a lot, and then there's a few foundational courses that the IPA teaches with fascial work and that kind of stuff, and just trying to get your train of thought around how fascia integrates into the body and what the function of fascia is. And so that's made it easier for me to pass along information and whatnot. And so it's nice to then be able to, I don't know, work with someone who's maybe further along in their career or has a better grasp of some of these things and use some of that upper coursework in conversations with them. So there's still a lot of challenges. And I think speaking from personal experiences, like breaking down that foundation, if it's not already in that realm of thinking through like function and thinking through these foundational things, without having that as the foundation, it's difficult to get to some of these higher level conversations and whatnot. So anyway, I appreciate what IPA pushes on anatomy and basic skills as far as like palpation, that kind of thing goes. And so I adopt that similar framework.
I've been lucky that a lot of the therapists in my clinic have actually taken some of the courses with me. So that's made life much easier. Especially even like a year ago, we had I think almost every therapist had taken at least one or two of the courses. So I feel like to a degree, we had kind of a common language that we could speak, even if we had taken different amounts of those courses. What I like is that I feel like my certification kind of provides some level of specificity. Like it teaches a lot of the basics. It has kind of a cause and effect. Like, okay, if I treat this, this is the effect I get. If I treat this, I get this. So you kind of come out and if you're like, what's one thing I can do? It kind of gives you that, where I feel like for me, even some of the AFS stuff it gets really broad and sometimes it's hard for me to wrap my own head around it. And I think that can be challenging for younger therapists too. I know it was for me. I think one of the things that's most challenging that I've had to work on for myself is if I'm doing a technique, an exercise, a PNF technique, whatever it might be, I have to retest it and I have to get the result that I was hoping for. And I feel like that's something that they kind of teach you in school, but you don't really get it in school. It's like we do a technique, we move on. We do a technique, we move on. But not necessarily stopping and seeing, did that technique elicit the result that I wanted? And was it enough that I'm happy with it, or do I want to do more? Because if I can do that, not only am I kind of testing myself, I'm teaching like, wait, did I get the result I wanted? But I can teach it to the patient, like, look, we just did this and we got this result. This is why we should be bought in. Not just that it feels better, it moves better. It's like, we got this amount of change right away. And I think a lot of us, when we come out, we're just trying to manage through so much information that it's hard to take those principles in. I think it can be challenging to take the extra 5 seconds to reassess and reevaluate, determine, do I need to keep going with that technique, or do I really need to look back and switch gears too?
Okay, let's talk a little bit about rigor, because all three of your paths have different amounts of rigor. And so take some time to articulate the rigor associated with that.
Sure.
Okay, go for it.
I feel like mine was challenging in one sense, although you could take the courses in any order and over as much time as you want. So there's not a time component to it, which is nice. Although you could finish it in about a year if you really want to push through it. The most challenging thing is just going into the courses kind of with an open mind, because it is a little bit of a free flowing thing where they have certain things they want to cover, but there's a lot of openness to it. And so whoever's in the class, the questions that they ask can really kind of shape it. But I think the challenge is taking those techniques, taking those assessments back to the clinic and trying it and struggling with it. I think that's where the hardest part was, and kind of taking those few weeks. I think I was glad I spread it out a little bit because it gave me time to find my own flow within those techniques. Because then you go back and you think it's going to be easy, and you have a real patient in front of you, and nothing responds the way that you think, and it's challenging. So I think the challenge is more so, how do I apply it, and forcing yourself to actually do it, because it is easy to go back to what you know and what you're comfortable with versus trying something different.
Can you talk a little about the test out process?
And then the test out process at the end is basically just a new patient evaluation, where you've got 2 evaluators watching you as you go through a complete initial evaluation, start to finish. Then you stop at different points, and they talk through your thought process so that you can kind of talk out loud as you're doing it. And so it's kind of intimidating because you're just in a room. It's like being a practical back in school again for over an hour. But it was good because it really did force you to put everything that you know into practice right in that moment. I was lucky enough to do it on one of the evaluators, so that was terrifying. But there's no formal written test for mine, although I know that there are for others that do a practical and a written test. But a lot of it is just like as you're engaged throughout, that kind of passes for their assessment, I guess.
The CFMT consists of 8 different courses. Each one of those courses, you are then written tested and practical tested on each one. You are required to fulfill this requirement in a 3-year time frame. Most people take these courses multiple times. They do give you a significant financial break if you do take it multiple times. So I took most of the 8 courses. I took most of them twice and a few of them 3 times. And then you traveled to a town in the mountains of Colorado. Starting to sound a little cultish here. And so you're
It's a small town in the middle of nowhere in
Yeah,
Michigan. It's
yeah.
the same thing.
yeah. But you're there for a week. You spend a few days reviewing all 8 courses as a group. So you're like covering a 3-day course in half a day. And then you go through your testing. So you got 2 days of testing. One day is 4 tests and 4 practicals, and then the next day is the same. And then you get your grades, and you have to have a certain cumulative score and a certain overall score, certain cumulative score, and then a certain score on each one to consider it passing. And then that's it.
Yeah, I mean, GIFT doesn't have a test out process or a practical or written exam. There is a small town you go to 3 times a year called Adrian, Michigan. That's cool. The rigor of GIFT is more, you have 40 weeks, and every week it's 5 to 10 hours of videos you're going to be watching, right? So you miss a week, then you're doubled up the next week. That's on top of treating your full caseload and doing your notes and all that kind of other stuff you need to do in your daily life. With GIFT, again, it's tough. You got to decide whether you can be an active or a passive learner, right? Because you can sit and just listen to 5 to 10 hours of videos every week and not really apply it, maybe learn a little bit. But if you're actively learning, you're stopping videos, you're taking notes, you're rewinding videos because you have new concepts you've never heard before, you're watching them a couple times, you're calling your mentors, you're calling your coworkers, you're going through it with you. You're doing your monthly clinic in-service mentorship every month to apply what you've learned. And then every Monday you walk in, you're looking at your patients saying, okay, based on what I learned last week, what am I changing? Because you are not treating the same going through GIFT as you did before GIFT. So again, passively, you can just go in and keep treating the patients the same. But if you're actually actively learning, you're going to be doing something new with every single patient because you learned something new the previous week. And after 40 weeks, it gets to be a lot. It's like a fire hose of information coming at you. You try to grasp as much as you can, but as much as you can change while you're doing it, that's how you're going to come out on the other side, having learned, having grown as a therapist. There was a couple weeks when I went through GIFT where I didn't do any table evals. It was all standing, just to prove I could do it to myself. I don't do that anymore, but you should, right? You should at least try. There's a way to do it. Maybe not for everyone, but so that's the kind of the rigor associated with GIFT.
So you all talked about the rigor associated with time commitment. So now let's talk about the financial commitment. If you felt the value was worth the financial commitment and all of that.
I think my coursework overall was around like $3,500, I think, something like that, with a little bit more, an extra cost at the end to do the test in person and everything too. I thought it was very valuable. Again, I thought it's changed how I've treated. It's changed how I work with patients, how I teach students, work with other therapists. So for me, it was very valuable. I thought it was a very good price overall for like 7 or 8 courses I think that I took. Although there's a lot of weekends of doing stuff and practicing, but I thought it was very reasonable for the amount of knowledge that I got.
I would say, so coursework, came to somewhere around like 6,000, but like with travel and lodging and all that kind of stuff, probably closer to 10,000 when all is said and done. It completely transformed my entire practice. So the confidence that I have, the value that I bring to the clinic, the mentorship that I can provide to others, like there's just so much that came from this and that gave me the confidence to do this, that, I mean, it's hard to put a price tag on that. So the price that I paid for that, I wouldn't think twice about it, but it was a lot, but I wouldn't even think twice about it. It was huge. It was something special.
Yeah, for gift, it's all your Con Ed that year, and then it's a 5-year employment agreement with Spooner. It's an expensive fellowship to go through. But yeah, I mean, extremely valuable, very, very well worth it. Definitely, you know, game-changing, paradigm shifting with treatment.
Well, the interesting thing about this, and having taken lots of IPA courses, also doing gift, the vast majority of people that I interact with, they're paying for all of this out of their own pocket. And so, you know, Nick already alluded to it, but just the support that we have from Spooner and the focus on continuously learning, whether that's you bring that into our core value or you bring that into a therapy success factor, just realize how uniquely blessed we are to have that as part of our foundation here, compared to, you know, you meet people at the middle of nowhere in small town Michigan, and people are flying from all over the world and they're paying for this out of their own pockets. They're paying $13,000, $15,000 plus travel and lodging and all of that. So, you know, I think Nick articulated it really well about it is invaluable, even though it's expensive. It's invaluable because of the transformation that it has on us as people and our ability to help our patients that show up every single day. So thank you for all articulating that. Okay, so let's talk what's next for you all. Like, where are your next steps in pursuing? I know you and I actually, Eric, I want you to talk a little bit about what you just took as you sat for OCS, and the differentiation between why you chose to sit for OCS and what that's done to solidify your role as an MSK primary care provider.
So I finished my COMT in September, and I basically started studying for the OCS at the same time. And it overlapped nicely. I thought, so for my COMT, I thought it was so beneficial for me as a clinician in treating the people in front of me who had musculoskeletal problems. I still felt like there was a part of me that was missing some of these yellow flags, red flags, and even differentiating, if we consider ourselves people who can triage and decide, do they need PT, do they need something else, do we need imaging? I didn't feel like I was very good at that. I think I probably missed a lot of things over time that maybe would require imaging or something potentially more serious. And so I took the OCS, which was good. I don't think it's transformed anything about how I practice, not significantly, not once the patient's in front of me and I'm working with them. But I think on that first day, second day, even just considering like just how they transform over time, making those decisions about when do you need imaging, is this something potentially more serious? Should I have something else in the back of my mind while we're treating this, and kind of do like a watchful waiting technique? I feel like I've gotten better with that. I've already kind of caught a couple people who've had some open fractures like in their wrist and hand and stuff like that too, which I think before I might have been cautious with, but I don't know if I would have been confident enough to say what they should do any which way. I do like some of the research that they talk about. It's kind of nice to feel up to date again after going through it in school. At least just knowing like, hey, for this type of pathology, here are things that generally work well and have been proven by research, which has its own limitations, but at least it gives you a starting point if you're searching for something. So it's some of those concepts. I think it's helped a lot with patient education, as far as timeline, prognosis, things like that. But what I do on the table or exercise wise, not always drastically changed, but I think they've kind of complemented each other pretty well because they're different domains.
Great, thank you. All right, so what's next? What are you pursuing next? Where's your clinical brain headed now?
So as I had mentioned before, like it seems the more courses I take, the more I realize that they're actually very closely connected. And so I want to take a visceral course. I plan on diving a little further into some more vestibular stuff. And then the IPA offers a lot more courses that I also want to take some. There's a pelvic girdle course and some other manipulation courses and stuff like that. So anyway, just some little gaps that I see where I'm not fully confident that while they may seem a little scattered, are in my mind very much connected, and just kind of the gaps that I still have in my care that I want to pursue. So those are kind of my next. And I need to take a TMJ course because apparently they all think I'm an expert. So
Everything. I've been doing more IPA stuff recently. That's what my goals for the year are. Again, diving more into foot, ankle, and orthotic stuff. So I'll probably keep an eye out for some courses with that. Maybe even some more dry needling stuff to just double down on.
I don't know yet. I think I might do some IPA stuff. I want to explore it. I've never done it. I've dabbled with the idea of the AFS fellowship, but I don't think I want to do that yet. But I do feel like I want to get better at some foot and ankle gait analysis, some of those mechanics. I think foot and ankle is an area where I still feel like I'm kind of lacking as far as what I can do treatment wise, and truly what it does in function. There's a lot of little bones that do a lot of things, a lot of little joints. So that's something I would like to look at.
Do we have any questions from the audience?
Here. 5 minutes.
Yep.
I do find it interesting that we have hand specialists, but not foot specialists. Well, but I mean, like, we have an entire department around the hand therapy, right? Our OTs are primarily working on that limb, and yet you take another area of the body that is very intricate as well, and like, we don't have someone who's just working on that, right? Like, I think the desire to be able to become more familiar and comfortable with treating that area is an overlooked area.
Yeah, it was one of those things where I felt very, very weak coming out of school. I just would ignore the foot and the ankle. That's all I wanted. So like I took 3 courses and 2 of the same course and kind of getting it, working on it.
Change the way you mentor.
So, yes. So Julianne asked, how has going through your advanced clinical certification changed the way that you mentor others?
I mean, if someone's asking me a mentoring question, I'm not getting them on the table. I'm not going to show them something that, you guys can't show a new therapist, but we're going to go up to the floor and say, okay, well, let's see how they move. Let's connect some dots, chain reaction wise. Let's look at some other body parts and try to treat that. That's how I mentor.
I think I've got a little bias towards like asking more anatomy questions in my mentoring. Again, just trying to bias those foundational things that I've learned that are a bigger part of that treatment philosophy than I realized. I feel like that's one of the big changes made for me, but then I don't know, also encouraging them to reach out on a regular basis and like, so go try this tomorrow and like reach out and like, let's talk about it. And I just feel more confident having those conversations over the phone or whatever and not having to have them in person. So I think it's changed my confidence level to where I can have those conversations that I don't have to be in person with them. I think that's big for me. Those are probably the biggest ways to change it for me.
I think I find if people are asking about a certain technique, I find myself going over the technique, but going over the clinical reasoning behind it too. So there's a why to why we're doing it and a reason for how we got there. We were talking about it a little bit earlier. I feel like if I'm mentoring anybody else, I like to be there with them and like with their patients if possible, just so I can we can put techniques to use in the moment. Where before it might have just been, let's just practice over lunch, which I still do. But it's nice to be able to have the person in front of you as well. So it's like you can kind of see its effect or lack of, and kind of talk about what next steps might be too.
Well, Nick, John, Eric, thank you very much for joining us on the therapist panel. Again, as a reminder, we will be doing a second part on July 16th, where these three gentlemen will be putting some of their clinical thought processes in application with a patient case. We were strategizing potentially a low back related pathology. And so please tune in for that. There will be additional emails coming out with the specifics. And thank you again, gentlemen, for joining us. We appreciate it.
Thank you.